Welcome to Women in Cardiology Global Case Competition. My name is Sarah Burkholzer. I'm currently a second-year cardiology fellow in the south of England. However, I'm currently on maternity leave. My aim is to specialize in heart failure and advanced imaging techniques, where I'm hoping to do a PhD. I have been appointed by the British Junior Cardiologists Association as Women in Cardiology and Flexible Training Representative. And as part of this role, I have set up a mentorship program for junior women in cardiology in the UK. And within this role, I've connected with Aaysha, Cader and Sabiha Gati, and we founded WIC Global Early Career. Thank you all for taking your time to join 10 fantastic women in cardiology from 5 different continents, showcasing their fantastic work. Welcome to all participants from different time zones all over the world who have registered to participate in this event. It is my honor to welcome the international panel of judges consisting of Amardeep Dastidar from the UK, Dr. Purvi Parwani from the US, Dr. Aaysha Cader from Bangladesh, and Dr. Sabiha Gati from the UK, all of which you will be meeting during this presentation. The most recent tweet advertising this event has been seen almost 10,000 times on Twitter. Our group, Women in Cardiology Global, aims to create opportunities for other women in cardiology and want to facilitate collaboration. So please may I encourage you to tweet about the cases, including the hashtag #WICcases. Out of 60 submitted cases, the top 10 have been selected to be presented today. The assistant editor of the European Heart Journal Case Reports, Dr. Fielder Cam, will not only announce the winning case at the end of this competition, but also waive the publishing fees. But before we start, I would like to thank my friends and colleagues, Dr. Sabiha Gati from the US and Dr. Nafisa Al-Samani from Sudan for supporting this event behind the scenes by shortlisting cases, leading the correspondence and promoting the event on social media. My very special thanks goes to Aaysha, who has been vital in supporting me organizing this event. But maybe the Global WIC team involved in this event would like to introduce themselves before we start with the cases.
Hi, I'm Aaysha Cader. I'm originally Sri Lankan, but currently based as a cardiologist training in interventional cardiology in Dhaka, Bangladesh. I hope to pursue a dedicated fellowship in complex coronary interventions, and I'll be starting an MSc in clinical trials this autumn. As Sarah mentioned, our global WIC collaboration is an effort to bring together particularly trainees and early career women in cardiology. We hope to identify our unique challenges, potential solutions, and in doing so, build a global network whereby we create opportunities and enhance visibility for women in cardiology, which is essentially the objective of this launch project.
Hi, I'm Dr. Nafisa Al-Samani. I'm currently working as general cardiologist at the National Center of Cardiothoracic Diseases and Surgery, Shab Teaching Hospital, Khartoum. It is my pleasure and honor to represent African country in this group. I have a special interest in advanced echo and pulmonary hypertension. By joining this group, I aim to establish a good connection and rapport so as to help our trainee and early career cardiologists in Africa, because I believe that having such joint group gives us a lot of power. So let us use this collective strength to draw up a realistic and practical roadmap for all women in cardiology.
Hi everyone, my name is Paola Morejon. I am from Ecuador, but I did my training in cardiology and fellowship in heart failure and transplant in Argentina. I have a special interest in acute cardiac critical care and mechanical circulatory support. I like to collaborate with scientific societies. I am convinced of the strength of sharing medical information through social media and the importance of supporting to cardiology's early career. I am very excited to connect with colleagues around the world. And remember, women support women.
Hi, my name's Louise Segan. I'm a final year cardiology trainee from Melbourne, Australia, and the Aussie representative on the Women in Cardiology Global Early Careers collaboration. I plan to embark on a PhD in cardiac electrophysiology next year in order to better understand the relationship between electrophysiology and heart failure management in Australia. I have been supporting women in cardiology locally for the last 2 years and have now joined forces with our other fantastic collaborators internationally to look at ways in which we can promote women in cardiology and academic medicine.
Hi, my name is Sabiha Gati. I am an interventional cardiology trainee at the University of Vermont, and I'm presently applying for a structural heart disease fellowship position. I have been privileged to be able to work with the American College of Cardiology Interventional Leadership Council and the Society for Cardiovascular Angiography and Imaging, which is the SCAI Structural Heart Council. I strongly believe that a world of cardiology needs to be more inclusive and that we need to address the existing gender and regional disparities. Our organization, Women in Cardiology Global Early Career, is trying to take a small step towards that effect. Thank you for all your support.
Welcome Dr. Shaya Beach, who's presenting a case about mitral annular disjunction arrhythmic syndrome.
Hi, thanks so much for having me. And thanks for that introduction. So yeah, my name is Shire Beach. I am a third-year internal medicine resident at UCLA, currently applying in cardiology. I put this case together with my wonderful mentor, Dr. Janet Hahn, who's an electrophysiologist at the VA Greater Los Angeles Healthcare System. It's entitled MAD Palpitations, a case of mitral annular disjunction arrhythmic syndrome. So getting right to the case, our chief complaint was palpitations. This patient is a 46-year-old man with a past medical history of hyperlipidemia, chronic low back pain, and intermittent heavy alcohol use who presented with 2 months of daily palpitations. He described the palpitations as a chest fluttering sensation with some associated shortness of breath, but had no chest pain and no syncope or pre-syncope episodes. Other relevant history was notable for a father who had suffered an MI in older age and underwent PCI for that. Notably, though, he didn't have a family history of sudden cardiac death. With regard to social history, he was an occasional light smoker, had a prior intermittent history of heavy alcohol use, but at the time of presentation was not drinking heavily, and denied any over-the-counter medications, herbal supplements, or illicit substances. With regard to medications, he was on a simvastatin 20 milligram tab daily, as well as baclofen is needed for back pain. Moving on to objective data, his vitals were notable for a heart rate in the 60s, and he had an irregular rhythm on cardiovascular exam, but no appreciable murmurs. Overall, he appeared clinically euvolemic. His basic labs are also included in this slide, and I want to draw your attention to the fact that his electrolytes were within normal range, as well as his TSH. This was his EKG at the time of presentation. These green boxes here are highlighting the recurrent PVC that we saw in this EKG. And I want to pause and give you a moment to think about where this PVC might localize to. So it localizes to the anterior lateral papillary muscle. And there are a number of important clues in this EKG that help us get to that localization. So first, I want to draw your attention to the green ovals that are highlighting the inferior axis with inferior lead discordance that you see, again, in those green ovals. Other notable characteristics of this PVC include the right bundle branch morphology that's outlined in the green triangle, as well as the late precordial transition outlined in those green rectangles seen in B5. So taken together, these findings are pathognomonic for anterolateral papillary muscle localization for that PVC. And what gets us specifically localization to the anterolateral pap is that inferior axis, whereas we would expect a PVC originating from the posterior medial pap to have a superior axis. On the right of the screen is a figure I adapted from a recent paper by Briseno and colleagues that summarizes typical ECG findings of PVCs originating from the LV PAP muscles. And these two patterns in particular that I've included on this slide most closely resembled the pattern that we saw in this patient's EKG, particularly when you look at that V1 lead in the adapted figure compared to what we saw. So after this clinic visit, the patient was referred to cardiology, and a number of further studies were ordered, including an echocardiogram, which is shown here. So we're looking at a parasternal long axis on the echo, and I want to draw your attention to the mitral valve where we see abnormal motion. We see abnormal motion there. And on the right side of the screen is a freeze frame of the main abnormality that we're seeing, which is a 7 millimeter mitral annular disjunction. And just to give that a definition quickly, mitral annular disjunction is detachment and atrial displacement of the aspect of the mitral annulus located under the posterior leaflet during systole. This patient was also noted to have mild bileaflet mitral valve prolapse. After echo, he was also ordered for a cardiac MRI with gadolinium enhancement. Most notably, this study demonstrated late gadolinium enhancement of the basal anteroseptum, which is highlighted in panel A with that green arrow. There was also a read of fibrosis of the anterolateral papillary muscle, but this was not as clearly visualized to us on the images that were available. And finally, the patient underwent ambulatory ECG monitoring, which was notable for a 14.1% PVC burden. So taking all these findings together, the structural abnormality of the mitral valve, along with this significant PVC burden, a diagnosis of the mitral annular disjunction syndrome was made. The patient next was started on metoprolol 50 milligrams twice a day, and pretty rapidly after this experienced significant symptom improvement. He underwent repeat ambulatory ECG monitoring after the beta blocker was started. And as you can see below, I've included the summary from the before and after ambulatory ECG monitoring, demonstrating that marked improvement in his PVC burden from 14.1% to less than 1%. And that brings us to our key learning points from this case, and there are a number that I want to go through. The first one is simply to recognize mitral annular disjunction. So again, this is a separation usually defined in the literature of at least 5 millimeters, a separation seen at that left atrial mitral valve junction, and it's seen during late systole. Pickelhaub sign is another sign on echo, sometimes seen associated with mitral annular disjunction. We didn't see Pickelhaub sign in this patient's echo, but it's good to know about. It's a spiked systolic lateral annular high velocity signal greater than or equal to 16 centimeters per second. And the figure to the right of the screen is showing a few examples of Pickelhaub sign. So panel E and F are showing examples of that, whereas G is the normal signal that you typically expect to see. And just for a bit of historical reference, Pickelhaub's, that name comes from this old spiked German military helmet, which you see in panel J, which I thought was kind of interesting. So after you recognize mitral annular disjunction, it's important to know the significance of what this means. And it really boils down to the fact that with this structural abnormality, this leads to increased mechanical traction at the level of the papillary muscles in the LV wall, and this in turn leads to fibrosis. This fibrosis can be seen on cardiac MRI with gadolinium enhancement, and the typical distribution of that late gadolinium enhancement is the inferobasal LV wall. That fibrosis can predispose to arrhythmias, and when you have again, that structural abnormality with the fibrosis and then the subsequent arrhythmias, that's how we make this diagnosis of the mitral annular disjunction arrhythmic syndrome. And recent studies have more and more really demonstrated this, that mitral annular disjunction is a strong independent predictor of ventricular arrhythmias, with arrhythmia risk increasing proportionally to the length of mitral annular disjunction. some of the important risk factors to know that predispose to severe arrhythmias include younger age, lower EF, higher PVC or VT burden, and papillary muscle fibrosis. And our patient had a number of these risk factors. Other things that can predispose to severe arrhythmias include bileaflet mitral valve prolapse in the presence of Pickel-Hobbs sign. And treatment for this syndrome, first line for medical therapy are beta blockers. And we saw in this case that they were highly effective for our patient. He really hasn't required further intervention. If that hadn't worked for him though, we would consider more invasive measures, potentially an EP study with ablation, repair or replacement of the mitral valve, and consideration of an ICD to prevent sudden cardiac death and severe arrhythmia. So in summary, the mitral valve can cause a lot of pathology in the mitral valve, can manifest as a lot of different things, and can classically we think about it leading to heart failure, but it's increasingly being recognized that abnormalities of structural abnormalities of this valve can lead to serious and life-threatening arrhythmias. And in this case, I think what was really neat that it highlighted was that this patient's really his palpitations and his initial EKG were really the first key steps in recognizing that he had this pretty substantial structural abnormality of his mitral valve, this mitral annular disjunction. So I'll stop there. Thank you so much for your attention and the opportunity to present, and I'm happy to take a few questions.
Thanks. It was an excellent case. And I have got one question. I would like to ask you, why do you think this case was unique from your point of view in terms of learning?
I'm having a little trouble hearing you, but I think you were asking what were the unique learning points for me from this case. And I think going back to just that last point I made here, that it was really this gentleman had a pretty significant structural abnormality in his heart, and it really was diagnosed primarily from that EKG, which I think is really cool. It was really fun to learn about how the characteristics of a PVC from just a couple of leads can map pretty precisely onto a structural abnormality on imaging. And in going through the imaging with my mentor, Dr. Hahn, it just highlighted the importance of really taking a look at the primary imaging that you're ordering to try to correlate with the question that you're asking. And for us here, it was, where are these palpitations coming from? So I thought that was really neat.
Thank you, Dr. Beach, for your case presentation. So the next case presentation is by Stephanie Liu from Geelong in Australia, and she's presenting a case of coronary vasospasm, which was an unusual cause of a VT arrest.
Perfect. Hi everyone, I'm Steph. I'm a first year cardiology registrar at Geelong, and I have an interest in cardiac intervention. So now I'll proceed to tell you about my case. So vasospastic angina is a variant form of angina first described by Prince Mental in 1959. And compared to angina that occurred on exertion, he noticed that this manifested at rest and was commonly associated with ST segment changes that promptly responded to sublingual nitrates. It's an important cause of transient myocardial ischemia due to coronary artery vasospasm and can often present with this chest pain and transient ST segment changes and can be complicated by ventricular arrhythmias. So the case I'm going to present occurred over a period of 2 months in an otherwise fit and well lady who unfortunately suffered from recurrent ICD shocks of unclear etiology. She initially presented to a small regional hospital with chest pain, and 5 minutes to arriving at the hospital, suddenly had an arrest with documented ventricular tachycardia and fibrillation upon arriving to the hospital. Fortunately, she did have return of spontaneous circulation after advanced life support, and the only abnormalities noted included a potassium of 2.8. She did have a raised troponin, and that was elevated at 6,363, but part of this raised troponin was thought to be in the setting of her undergoing CPR. So a bit of background about her. She was an otherwise fit and well lady with the only past medical history being notable for depression, and her only cardiac risk factor was smoking, which she ceased on presentation. She had no family history of cardiac disease and also no family history of sudden death. Prior to that presentation 2 months ago, she was on no medications, and socially, she was fit and well, had run half a marathon about a month and a half before, and was from home with her husband, working full-time in an ice cream factory. She also denied any alcohol or recreational drug use. So during that 2-month period, she had a myriad of investigations to find out what was the cause of a ventricular arrhythmia. So on her index admission, she underwent a coronary angiogram, which showed no obstructive coronary artery disease. She also underwent a transthoracic echocardiogram, which showed a normal LV function with a negative bubble study. During that admission, she had further episodes of nocturnal chest pain as well as chest pain at rest. And on one of these occasions, it was associated with these ECG changes as noted on the right side of the screen. So she had ST elevation in leads 1 and AVL. And while we were tossing up whether to bring her back for an urgent angiogram, these segments resolved, which is the ECG on the bottom right-hand corner, just 10 minutes after that episode when she was pain-free. Because of that, she was discussed at our multidisciplinary meeting, and the plan was for her to undergo a cardiac MRI looking for any signs of scar, but that only revealed subtle hypokinesis of the anterior wall, which again raised the possibility of myocardial ischemia. And so because of the MRI findings, she subsequently underwent a CTCA as well as a myocardial perfusion scan. And these were normal with the CTCA showing a calcium score of 0 and the myocardial perfusion scan showing no inducible ischemia. In the background, I guess there was a differential of whether this could be myocarditis, even though her cardiac MRI didn't suggest otherwise, but she underwent a PET scan, which once again did not have any active uptake and ruled out myocarditis. In terms of her treatment, so she was initially commenced on beta blocker therapy to try to prevent any further episodes of ventricular tachycardia, and subsequently also had nitrate therapy introduced given her ongoing episodes of this chest pain. However, a lot of the therapy was limited in the setting of her having a low baseline blood pressure. After our multidisciplinary meetings, initially she was planned for a subcutaneous device given her young age. However, due to her recurrent episodes of ventricular tachycardia, the consensus was that she should have a dual chamber ICD implantation for its anti-tachycardia pacing function. Unfortunately, despite the escalation of all of this beta blockade, she still suffered from a lot of trauma in the setting of having recurrent shocks by her ICD in the community. And while she was an inpatient again, she had further episodes of VT despite being placed on amiodarone and was subsequently commenced on a lignocaine infusion. After multiple discussions, I think the differential at the back of everyone's mind was that this could potentially be coronary vasospasm, given the history of chest pain and self-resolving ST elevation preceding these events. So it was thought that beta blockade should be changed to a calcium channel blocker. and fortunately, she has had no further shocks since. Provocative testing was raised. However, given all the trauma that she had sustained from her shocks, it was thought that we would trial the calcium channel blocker, which is a much more conservative management approach than unnecessarily putting her through all the provocative testing. So I guess this case just really highlighted how vasospastic angina can be a diagnostic dilemma, as shown by how it took quite a while to actually reach this diagnosis and actually get this improve this patient's quality of life, because she was just in and out of hospital with recurrent ICD shocks and episodes of VT. It should be considered in younger adults with few cardiovascular risk factors, just like in this patient who was otherwise fit and well. And often we should look specifically for a trigger. And in this case, smoking has been related as a precipitant for coronary vasospasm. So we should be seeing whether any of these lifestyle modifications can be implemented. And lastly, implantable cardioverter defibrillator insertion is still debatable, but should be considered after prognosticating the risk assessment following such a serious arrhythmic event. And I think in this patient's case, given the sheer multitude of how many events she had, it was thought that the benefits of inserting an ICD would definitely outweigh the risk of inserting it. So just to reiterate the learning points, so coronary vasospasm is a rare but important cause of myocardial ischemia, and it should be definitely a differential when we work people up for ventricular arrhythmias. Secondly, we should encourage our patients to avoid any precipitating factors that we have identified while working them up. And medical therapy with calcium channel blockers remains the foundation of management. And lastly, ICD therapy may be of benefit in high-risk patients. Thank you. And these are just my references.
Thank you very much for presenting this fantastic case. The judges have 2 questions for you.
All right, Stephanie, thanks for the case. I just have one query regarding the diagnostic angiography. Did you test for vasoreactivity specifically, or did you do an FFR, CFR, IMR? Did you do diagnostics along the lines of INOCA?
We didn't, and I guess that's one thing that we should have explored. In terms of why we didn't do an FFR, it was mostly because a lot of her coronaries looked very smooth, and there was nothing to suggest that there was even at least a moderate stenosis that could potentially be FFR positive.
All right, thanks.
Okay. Thanks, Stephanie. This is the other moderator. So excellent case. I have got a question. So why do you think this case is unique from your perspective?
I think it's unique because normally when we're working patients up for ventricular tachycardia, we look for a scar or we look for ischemia. And in this patient, the ischemia wasn't as straightforward as you would think, because normally if you could see an obstruction on the angiogram, you just hit the nail on the head and open up that blocked vessel. And hopefully by establishing flow down that vessel, you could say that you can prevent these recurrent episodes of ventricular tachycardia. But in this patient, the ischemia was a bit harder to identify given there was no obstructive lesion, but it was evident on her ECGs. And I think it's interesting in the setting where it affects younger patients, and a lot of women are affected by it. So it's not your straightforward ischemia causing VT case. Yeah. And I think a lot of research still needs to go into whether ICD implantation is actually beneficial. There have been a few studies that show it is, but I think it's not done in a large enough cohort to standardize whether it should be done.
Thanks. Excellent.
We have a short time left, and maybe you would like to highlight what your involvement in the case was.
Yep, so this case was interesting because it was literally the first weekend I was on as a cardiology registrar, and I was really nervous going to it, and she presented after, and I guess it was pretty traumatic given she was such a young patient, so you tend to get more involved. And I guess it just continued throughout our registrar months, whereby we still couldn't find a diagnosis. And since it was the first weekend, I was just very involved in trying to help her and trying to improve her quality of life and seeing her suffer through these 2 months. And to finally get to that diagnosis whereby she was free of these episodes of VT was very rewarding. And that's probably why, yeah, I found it very interesting.
Thank you very much for presenting this case.
Thank you.
The next case presentation is about spontaneous coronary artery dissection in a pregnant patient by Dr. Kimberly Odell from the US.
So my name is Kimberly Odell. I'm a third-year internal medicine resident at the University of Tennessee in Chattanooga, and I worked closely with the cardiology fellow, Dr. Weingarter, in writing this case. So I'll go ahead and get started. This case is about a 30-year-old female who presented at 32 weeks pregnant to the ED with chest pain that started about an hour prior to her presentation. She also had some associated shortness of breath. She had never had chest pain like this before and had no cardiac history, no really cardiac risk factors. In the workup that was done in the ER, she did have ST elevations that were about 5 to 6 millimeters in the anterior and somewhat into the lateral leads. And she also had a slight troponin elevation. So she rolled in for an ST elevated MI, and she was taken emergently to the cardiac catheterization lab. There she underwent coronary angiography, and it did show a proximal LAD dissection with a forming intramural hematoma. And I've attached her EKG here, and then that is her coronary angiogram as well. So what happened next for her is the interventional cardiologist considered PCI for her at the time. However, given her hemodynamic stability, they decided against that. Also, her chest pain had resolved immediately prior going to the cath lab, so they decided to pursue more conservative management for her. The next steps with her were that since she did present initially to a rural hospital, they did not have any maternal fetal medicine or high-risk pregnancy services to offer there, so they did decide to transfer her to an academic tertiary center, which was our facility. So they transferred her there for maternal fetal medicine, and in the event that she required any further cardiac care. So during transfer, she did have a return of the chest pain. It was severe substernal. She became very mildly hypotensive at that time as well, but still relatively stable. Upon arrival to our facility, an echocardiogram was performed, and it showed a very significantly reduced ejection fraction of less than 20%. So at that time, all the teams were notified that she was en route before she actually arrived. So we had the maternal fetal medicine provider, we had cardiothoracics, interventional cardiology, general cardiology, and anesthesia all on board for her. And there were very early multidisciplinary planning discussions for her. Anesthesia actually wanted to, or they were pushing for her to go ahead and have a cesarean section for delivery. And then the plan was to go for a bypass surgery at that point. However, pretty much everyone else decided against delivering, and they wanted to have her, since she was only 32 weeks, they wanted to keep her pregnant at least as long as they could to maximize the potential for a better outcome there. So they decided not to do a C-section, and they decided to go and pursue a bypass surgery. During all of this, before she actually went to the OR, she did further decompensate, and she developed some flash pulmonary edema, became very hypotensive, basically a shock, a cardiogenic shock, and she did end up going back to the cath lab to have an Impella placed for hemodynamic support. So there was a lot of ongoing discussions with the patient and her family as well about the risks for mechanical circulatory support during pregnancy. There's not a lot of data, not a lot of case reports, information out there about the effects of that on the child or the fetus. So they were very open in their discussions with her about the risk, and the family wanted to maximize the mother's opportunity for a better outcome. So they decided to go ahead and place the Impella, and then after that, she became a little more stable and then went to the OR for her bypass surgery. So she did get a 2-vessel bypass after that, and she did well, had no complications during the surgery, really no significant complications throughout her hospital stay. They were able to remove the Impella on post-op day 3. The only thing I would say that was a complication would be non-sustained VTAC. However, it didn't really cause any hemodynamic compromise in her. It was just noted on telemetry, and again, that wasn't unexpected, giving her acute heart failure. For her medical treatment during hospitalization, we did start her on a beta blocker. We chose metoprolol tartrate for her because of the easy ability to titrate the doses. And she was also given furosemide kind of as needed to maintain euvolemia throughout hospitalization. Additional guideline-directed medical therapy, including ACE inhibitors, angiotensin, ARBs, and then spironolactone are contraindicated during pregnancy. So we did hold off on all of that until her outpatient follow-up. She did undergo continuous fetal monitoring during her hospitalization. Most of her fetal tracings were category 1, some category 2, but mostly everything was stable with in that regard. And she did have several repeat echocardiograms during her hospital course that showed some mild improvement in her ejection fraction, up to 30%. She never did get above that. And that was about a month after her bypass. So she had maternal fetal medicine, obstetrics. They did see her throughout this hospitalization, and their goal was to plan for delivery at term, or around 37 to 39 weeks. And they did meet as a multidisciplinary team with the cardiology services about 3 times a day because of her kind of tenuous picture. And they did decide that she was optimally stabilized around week 38. So she did remain in the hospital for about 6 or so weeks for continuous fetal monitoring and cardiac monitoring. After her bypass, she was in the cardiovascular intensive care unit for a couple weeks, and then she was able to transition to the high-risk perinatal unit for more fetal monitoring. And the plan for her delivery was to bring her back to the cardiovascular ICU so we could monitor her cardiac status very closely during the delivery period. So she returned to the ICU. She did get an early epidural, and then labor was induced on her post-op day 41 following her bypass. And everything progressed well, and she did have an assisted second stage of labor with forceps and vacuum assist. And that resulted in the delivery of a healthy little boy. Additional medication for her is she did receive a dose of furosemide upon clamping of the cord, and that was to mitigate the volume changes that come with delivery. And she had no complications related to any volume changes. We monitored her for another couple of days in the hospital after delivery, and she did well and was discharged on postpartum day 2. additional information for her is she did follow up as an outpatient, and she did very well. Her EF about a year out never improved beyond 30%. So she did go on to get an ICD for primary prevention. And her guideline directed medical therapy was initiated as an outpatient, and she's currently working and able to function and live a normal life. So just an overview of spontaneous coronary artery dissection. It affects women more often than men. And it is something to be cognizant of and to consider anytime a younger woman, or particularly a pregnant younger woman, presents with acute chest pain or acute coronary syndrome. It does cause about 20% of acute MI in women, younger women and pregnant women. And these women often do not have the traditional cardiovascular risk factors for MI. They may have other risk factors, namely connective tissue disorders, fibromuscular dysplasia, any kind of systemic inflammatory etiology, and hormonal fluctuations, typically with pregnancy, do lend somewhat of a predisposition for this disorder. The typical presentation of spontaneous coronary artery dissection is your chest pain. They can have shortness of breath. Typically, they'll have elevated cardiac enzymes and EKG changes consistent with ischemia, and they may even present with cardiogenic shock. And then it's important to maintain a high suspicion for this disorder, particularly if they do not have your classic risk factors for atherosclerotic coronary disease. And the management of this does differ slightly from atherosclerotic coronary disease. You do want to pursue early coronary angiography, just to clarify the picture here. So I made this flow sheet of a SCAD management. So basically, if you have this patient, you do early angiography, you see that they have coronary dissection. If they're stable, conservative management is a reasonable option, and you do want to monitor these patients inpatient. And that is if they don't have a high-risk lesion, which would be defined as a left main or multi-vessel dissection. If the patients are stable and they do have a high-risk lesion, they do recommend going ahead with revascularization. It doesn't necessarily have to be emergent at that point, but that would be the recommendation as opposed to a PCI. And if they're unstable, clearly you would pursue urgent revascularization. So the take-home points for this case, again, you want to maintain a high index of suspicion for coronary artery dissection, particularly with your younger women or pregnant women who present with chest pain. The next thing would be to just go ahead and compile a multidisciplinary team and have ongoing consistent discussions regarding the care. That would be to minimize any kind of maternal or fetal mortality or complications related to this. And you also want to have a clear plan, and you want to have backup options, because at any point anything could happen, the course could change. And the third take-home point regarding this case is there's definitely a lack of information, a lack of there aren't many case studies and recommendations as far as using mechanical circulatory support in a pregnant patient. So we didn't have a clear guideline of whether to go ahead and take her to the OR versus using Impella or a balloon pump or ECMO or those other options. So you kind of have to tailor your care to the specific case. And in this case, the Impella did work out well. It didn't cause any complications, and there were no noted defects within the fetus or anything like that. So it's just something that we need more data on, but it's hard to have a good study with that ethically.
Welcome, Dr. Ruth Chow, for presenting a case about arrhythmogenic cardiomyopathy.
Hi, thank you everyone. I'm Ruth Shao. I'm one of the cardiology fellows at University of California, Los Angeles. And I'm very grateful for this opportunity here to present an interesting case on behalf of my colleagues, Terry Nguyen, our postgraduate student, Judith Fan, our genetic counselor, Megan Kalmuth, our heart failure and transplant specialist, Greg Fishbein, our cardiac pathologist, and Jessica Wang, one of our cardiologists specializing in genetics. The title of our case is Arrhythmogenic Cardiomyopathy in Disguise, the role of genetic testing in peripartum cardiomyopathy and familial implications. The etiology of cardiomyopathy can be difficult to diagnose. Looking at pre-transplant clinical diagnosis and comparing that to post-transplant pathological diagnosis, there's an error rate of about 8 to 20%, with the majority occurring in non-ischemic cardiomyopathy patients. And looking more specifically at peripartum cardiomyopathy, about 15% of cases based on retrospective studies have a genetic cause that may have altered therapeutic decisions. Thus, genetic testing can serve as a complementary tool to 1, provide accurate diagnosis, and 2, allow appropriate guidance for family counseling. Our case is about a 36-year-old woman with peripartum cardiomyopathy who presents for heart transplantation evaluation. Her family history is negative for any known heart disease. Previously, she was a healthy person who played competitive sports in childhood, and she had an uncomplicated first pregnancy at the age of 22. 3 years later, her cardiac history began when she was in the second trimester of her second pregnancy. She was diagnosed with peripartum cardiomyopathy and ultimately terminated her pregnancy. Her ejection fraction remained low, so she underwent an ICD placement for primary prevention at the age of 32. A couple years later, she had an unplanned pregnancy with hopes of bringing it to term with close monitoring. However, her heart failure worsened, and this resulted in another termination. Afterwards, she developed atrial fibrillation and received multiple ICD shocks for ventricular tachycardia. At the age of 37, she underwent both a heart and kidney transplant. During her heart transplantation evaluation, her chest radiograph demonstrated in Figure A shows marked cardiomegaly. Her electrocardiogram in Figure B shows normal sinus rhythm, premature ventricular contractions, signs of conduction abnormalities with intraventricular conduction delay, and repolarization abnormalities with anterior precordial T-wave inversions and QRS fragmentation. Figure C shows her transthoracic echocardiogram that demonstrates a severely reduced left ventricular systolic function with marked left ventricular dilation, severe biatrial enlargement, a normal right ventricular size, and a mildly reduced right ventricular systolic function. After her heart transplantation, her native heart was further evaluated with pathology. In Figure D is a gross photograph of her native heart that shows epicardial adipose tissue infiltrating into the myocardium as demarcated with the arrows. And this involves both the right and the left ventricles. Figure E is microscopy that shows fibroadipose tissue labeled F infiltrating from the epicardium into the underlying myocardium labeled M. This established a diagnosis of arrhythmogenic cardiomyopathy for a patient. She did undergo further testing with genetic testing that revealed a pathogenic mutation in desmoplakin. Desmoplakin is a gene that encodes for desmosomes and is associated with arrhythmogenic cardiomyopathy. Arrhythmogenic cardiomyopathy, or more commonly known as arrhythmogenic right ventricular cardiomyopathy, is a result from abnormalities from desmosomes, which are intercalated discs that provide cell-cell contact and myocardial strength. When there is a breakdown of this mechanical strength, there is myocyte necrosis that occurs, leading to fibrofatty infiltration and aneurysmal thinning. The diagnosis of arrhythmogenic cardiomyopathy can be challenging despite the best efforts of the 2010 revised ARVC task force criteria, which has a sensitivity of about 70%. And this is in part due to the fact that this is a progressive disease. Not all clinical manifestations are present at birth, and that there is a wide range of clinical symptoms, and there's a lack of specific diagnostic criteria. Genetic testing can help with the diagnostic workup. The most common mutation is plakophilin 2, which also encodes for desmosomes. Desmoplakin mutations which is seen in our patient, was actually the first genetic etiology to be identified, is more rare and can cause more biventricular or left dominant arrhythmogenic cardiomyopathy, and is associated with a higher risk of malignant ventricular arrhythmias, sudden cardiac death, and end-stage heart failure. Interestingly, family history may be non-contributory, despite this being a predominantly autosomal dominant inheritance pattern, and this is because of decreased or age-related penetrance and variable expression, so a wide range of phenotypic expression despite patients having the same pathogenic mutations, or the possibility for de novo mutation and autosomal recessive inheritance, which is part of a cardiocutaneous syndrome that involves not just cardiac findings, but also skin and hair findings, because desmosomes are not just located in the myocytes, but are also found in skin and hair. Our case highlights, very importantly, the need for a high index of clinical suspicion for patients with ARVC. Our patient's presentation was masked by several features, including one, the temporal relation to her pregnancies, which led to a misdiagnosis of peripartum cardiomyopathy, the lack of symptoms prior to diagnosis, particularly in the setting of active and strenuous physical exercise, and the fact that there was no known family history of cardiac disease, which we now know does not rule out the possibility for a genetic cause of cardiomyopathy. Important key points to remember is that clinical symptoms are widely varied in arrhythmogenic cardiomyopathy, and this is due in part to the decreased penetrance and variable expression. Disease involvement can be it can involve both ventricles or be even left dominant and not just involve the right ventricle, which is where most of the diagnostic criteria based off of the task force criteria is focused on. So genetic testing can really serve to complement a clinical and pathological suspicion as demonstrated in our case. And the utility is not just limited to securing an accurate diagnosis for the patient, but perhaps even more importantly, expanding this to allow for appropriate mutation-specific screening for family members. And this is important because this will provide improved AC-related mortality, because we know that even in asymptomatic carriers, there is a clear relationship between disease progression and physical exercise. And in cases where, in patients who are screened as part of the familial screening, about 40% of cases that are positive for ARVC are actually in their asymptomatic phase. So the implications are great. Future directions involve better understanding of genetic variations across cardiomyopathy and the interaction between hormonal and perhaps even more importantly, hemodynamic changes seen in pregnancy with those with known cardiomyopathy-related mutations. Based off of registry data, in those patients with arrhythmogenic cardiomyopathy who undergo pregnancy, this appears to be pretty well tolerated. And those who do develop heart failure have marked right ventricular abnormalities. However, pregnancy leading to an initial diagnosis of arrhythmogenic cardiomyopathy is less well understood and perhaps, like our case, can be misdiagnosed as peripartum cardiomyopathy. So this really speaks to expanding research and evaluating the role of genetic testing for peripartum cardiomyopathy patients. Finally, a few learning points about our case. The diagnosis of AC requires a high index of clinical suspicion due to the unique specific diagnostic features and the large spectrum of clinical manifestations. AC is not only limited to the right ventricle, but can have biventricular or left dominant involvement. And genetic testing can provide an accurate diagnosis and allow for appropriate counseling of at-risk family members, particularly those who participate in intense physical exercise, as disease progression occurs even in asymptomatic carriers. Identifying individuals who harbor this pathogenic mutation is crucial, given the risk of sudden cardiac death. These are a list of my references. I'm very grateful for this opportunity, and thank you so much for listening.
Thank you very much for a fantastic case presentation. May I just ask you a question about your involvement in this case in particular, as it's been it's a long history of this patient. At what stage have you been involved?
I was involved more in the after she received her transplant. So during her cardiomyopathy rotations, we do an echocardiogram beforehand, and that's where I actually got to meet her and then learned about this history, and thought it was a very interesting case with a lot of teaching points.
Dr. Shao, that was a great case, very fascinating. I was going to ask you, do you think that pregnancy triggered, the entire presentation? Because it seems like, she may have had it, but I mean, it's hard to believe that throughout the pregnancy, she didn't get an echo, and if she got the echo, if she had any symptoms, she may have got an echo, then, this peripartum cardiomyopathy diagnosis, it just sounds like, I'm not sure how it was diagnosed in the first place, or was it that she was never, brought to a cardiologist attention when she was pregnant, and later on it was just thought to be peripartum?
Yeah, I think that's a very good question. And I think that's the interesting portion of this case, because I think there was a lot of anchoring because her symptoms developed around her pregnancy. And so a diagnosis of peripartum cardiomyopathy seemed to be the most reasonable one when there wasn't really anything else that the prior cardiologist had really found. I think some points in
after pregnancy, right?
She came to us after pregnancy.
Yeah, so you're saying that the diagnosis was established because her symptoms started after pregnancy, not during pregnancy, because that's my point, that if it was during pregnancy and someone would have echoed her, then this would not be the diagnosis she would be carrying, right? Yeah,
so during her second pregnancy, it was during her second trimester that's when she was diagnosed with peripartum cardiomyopathy. And I think because her arrhythmogenic cardiomyopathy was much more left dominant, so there wasn't really much right ventricular abnormalities that was seen. And so it didn't really lead down the path of arrhythmogenic cardiomyopathy. And the fact that she played competitive sports, and we know that in patients who are competitive athletes, they usually present with arrhythmogenic cardiomyopathy in the setting of intense physical exercise. So I think there was a lot of anchoring bias and just latching on to different parts of the clinical history to fit a clinical diagnosis. And when she came to us with the diagnosis of peripartum cardiomyopathy, this was additionally anchored on as well, because everything just kind of seemed to fit the timeline. And it wasn't really until after we evaluated her native heart after her heart transplant that we saw, wow, there's a lot of left ventricular involvement, and this looks like fibrofatty invasion into predominantly the left ventricle, which fits her pathogenic mutation, and then secured the diagnosis.
No, that's a great point. But my question is still, peripartum cardiomyopathy, by definition, it is the diagnosis that is given either during the last month or 6 months after the delivery. So was it thought that she was carrying it from before, after the first pregnancy, and just carried all the way through? I'm just not clear how the diagnosis was given in second trimester when the definition itself doesn't involve the second trimester.
Yeah, that's a really good point. And I'm not sure how it was decided to be diagnosed formally as a peripartum cardiomyopathy when she was in her second pregnancy, because it was 3 years after her first pregnancy, and her first pregnancy was uncomplicated. So I think, trying to think about what the cardiologist may have thought about during that time, it might have just been there was no other identifiable cause, and this might have just been the diagnosis that they decided to come up with, even though it didn't clearly follow the timeline of diagnostic criteria for peripartum.
Great, thank you.
Thank you so much.
The next speaker is Dr. Pragya Ranjan from New York, who talks about cardiovascular imaging in the era of COVID.
Thank you, Sarah. My name is Pragya Ranjan, and I'm one of the Advanced Cardiac Imaging Fellows at the Icahn School of Medicine at Mount Sinai. Thank you again for letting me present today. The topic of my presentation is multimodality cardiac imaging for management of a cardiac mass in the era of COVID-19. A 54 34-year-old female presented to the ED with the chief complaints of subjective fevers, chills, nausea, vomiting, and right lower abdominal pain that had been ongoing for 2 days. She stated that the fever started 1 week earlier, and at that time, she also had an associated non-productive cough. Her symptoms worsened acutely 2 days prior to presentation. Her past medical history was significant for non-obstructive coronary artery disease, hypertension, insulin-dependent diabetes, and hyperlipidemia. Her home medications included low-dose aspirin, duloxetine, irbesartan, levothyroxine, metformin, rosuvastatin, and long and short-acting insulin. She had no history of alcohol, tobacco, or other illicit drug use, and no relevant family history. Her drug allergies included hydrocodone and ampicillin. Initial vitals in the emergency room were as follows. She was febrile with a temperature of 103. She was tachycardic with a heart rate of 120. Her blood pressure was 155 over 107, and her respiratory rate was 20, with an oxygen saturation of 97% on room air. Pertinent findings on physical exam included an altered mental status, dry mucous membranes, and regular tachycardia on auscultation. Routine labs performed in the emergency room revealed the following. She had a mild hyponatremia with a sodium level of 131 and a mild hyperglycemia with a glucose level of 225. She had mildly elevated LDH at 291, D-dimer at 1.99, and fibrinogen at 840. The remainder of the labs, including a complete blood count, cardiac enzymes, that is troponin I, coagulation profile, including PT, PTT, and INR, lactate and urinalysis were all normal. EKG, chest x-ray, and a non-contrast enhanced head CT that was performed due to altered mental status was also normal. A CT abdomen and pelvis with intravenous contrast was performed because of her presenting symptoms, and this revealed a sharply demarcated area of hypoenhancement of the left renal superior pole consistent with a left renal infarct. Additionally, an incidental finding was a round mass in the left atrium that was concerning for a left atrial thrombus. A SARS-CoV-2 PCR performed in the ED was positive. She was started on antibiotics due to concern for COVID infection and intravenous heparin drip based on CT findings that suggested that the left atrial mass was a thrombus, and she was urgently transferred to Maine Mount Sinai Hospital for evaluation by cardiothoracic surgery. The question at this point was, what is the differential diagnosis of a left atrial mass? And this includes the following: a thrombus, a myxoma, a lipoma, various different types of sarcoma, and a metastatic lesion. So she underwent a transthoracic echocardiogram, and the images here on the right, starting with the top left corner, this is the parasternal long axis view on transthoracic echo, which reveals a round lesion in the left atrium. Seen a little bit better here on the apical 3-chamber view. It's clearly attached to the interatrial septum and is, again, rounded. And then on a short axis view cine clip, we can see that it has somewhat of an irregular surface and finger-like or frond-like projections, which is more concerning for a myxoma than it is for a thrombus. So the next step at this point was to confirm that this was likely a myxoma and not a thrombus, and so we had to choose another modality of imaging. To note, this was at the peak of the COVID pandemic in New York around April this year, and so it was decided that a transesophageal echocardiogram would be too high risk, given the risk of aerosolization during the procedure. So our choices were cardiac CT and cardiac MR. And because of the ability of cardiac MR to accurately perform tissue characterization, we proceeded with a cardiac MRI. The top left image here is a cine clip of a 4-chamber SSFP cine on cardiac MR, which again reveals a mass in the left atrium. This is a still frame of the same. On T2 weighted imaging, the mass appears hyper intense or bright compared to the rest of the myocardium, suggesting that it has high fluid content, which is also seen with the myxoma. On T1 weighted imaging, the mass appears iso-intense or the same contrast as the myocardium, ruling out effectively a lipoma, which would appear bright on this sequence. On first pass perfusion imaging, we can see that there is mild enhancement of the mass. This is a still frame of that same sequence, which we would not expect with an avascular structure such as a thrombus. And on late gadolinium enhancement imaging, we can see that there is a heterogeneous pattern of gadolinium uptake on both the 2 and the 4 chamber, again, classically seen in masses like myxomas, which have areas of necrosis, calcification, and hemorrhage. So we were able to say confidently that the mass was likely a myxoma and not a thrombus, and we communicated these findings to the surgery team, who had a long discussion amongst themselves as well as with the patient and the patient's family. And because of the somewhat tenuous respiratory status of the patient, decided to defer surgical resection of the mass until after complete resolution of the infection. And in the meanwhile, they recommended continuing short-term anticoagulation with apixaban 5 milligram twice a day. Their rationale for this was twofold. Firstly, COVID-19 patients have a high predilection for thrombus formation. And secondly, to prevent recurrent embolization in a patient that had evidence of prior renal infarct on the initial CT abdomen. After 6 weeks of anticoagulation and after complete resolution of the infection, surgical resection was successfully performed, and histopathology confirmed that it was a myxoma with a small layer of superimposed thrombus. Patient did very well postoperatively and was successfully discharged home. So a short discussion regarding this. Cardiac masses are rare, and atrial myxomas are the most common benign cardiac tumors. They're predisposed to developing superimposed thrombi, especially if they have a villiform surface, and can cause embolization of either tumor tissue or of thrombi. While the diagnosis and management of atrial myxomas is typically straightforward, it becomes a little more complicated in the setting of COVID-19 infection. We know patients with COVID have a high risk of developing arterial and venous thrombi. It is likely that patients with atrial myxoma and concurrent COVID-19 infection have a higher likelihood of developing superimposed thrombi, resulting in recurrent embolization. In certain cases, in patients with COVID-19, short-term anticoagulation is recommended based on a recent expert panel consensus statement. So our case demonstrates how multimodality cardiac imaging can be safely taken into consideration in specific urgent scenarios in patients with COVID-19, according to recent guidelines, and how to choose the appropriate imaging modality. Cardiac MRI is an excellent imaging modality to differentiate thrombus from cardiac tumors, and it is low risk compared to transesophageal echo. Our case also demonstrates how we used a short-term anticoagulation approach in our patient with atrial myxoma and concurrent COVID infection until there was complete resolution of the infection and the patient could be safely taken to surgery. So the key learning points are: 1, how to choose the appropriate cardiac imaging modality in patients with COVID-19 and how to safely perform these tests in accordance with the most recent guidelines, to review cardiac MRI features of atrial myxoma and how to differentiate myxoma from thrombus, and to demonstrate how a short-term anticoagulation approach can be considered in patients with atrial myxoma and concurrent COVID-19 infection until surgical resection can be safely performed. And with that, I'll conclude my presentation, and I'm happy to take questions.
Thank you,
Sarah,
Pragya.
go first, right?
Yeah, thank you, Pragya. Those were some impressive images and a very impressive approach as well. Could you tell us a little bit, as you mentioned, you were an advanced cardiac imaging fellow, to what degree your involvement were in deciding which approach you should be taking and which imaging modality should be prioritized, and perhaps a bit of a focus on why you didn't go for a TE as well?
Absolutely. So the way that multimodality imaging works, we work together very closely as a team at Mount Sinai because we have one large reading room where the echocardiographers, the CT, MRI readers, vascular, everyone sits together. And when this patient was referred for a transthoracic echocardiogram, and we reviewed the transthoracic echo images with the director of echo, Dr. Croft, she said this looks more like a myxoma in her experience of over the years, as opposed to a left EKG that was done at the hospital the patient was referred from. And we reviewed the images with her, and it seemed like that to us as well. So she discussed with us whether it made sense to proceed with MR or whether we should consider a cardiac CT because we were the MRIC. For a while, we were CE for the patient. In fact, I believe it was ordered, but we talked about it a little bit more. And we were, again, this was April in New York, it was peak of COVID. And we were really, really reserving TE cases for patients that it was absolutely necessary that we could avoid, transmission between the physician, the echocardiographer, and the patient, of course. And we explained that we have a cardiac mass protocol. We've looked at these cases many times in the past. It is to a high degree of accuracy, we can rule out a thrombus in cardiac MRI. And we will be able to say, this is likely more a myxoma than a thrombus. And, we explained all of this, we had that discussion, and that's when we decided, okay, it makes more sense to proceed with a cardiac.
If I can get Purvi. Thank you, Dr. Pragya Ranjan, for presenting such a fascinating case about the challenges of cardiovascular imaging in the era of COVID. Now we're halfway through our cases, and I would like to invite the judges to introduce themselves.
Hello everyone, my name is Sabiha Gati. I'm a consultant cardiologist at the Royal Brompton Hospital in London. My subspecialty interests include sports cardiology, inherited cardiac conditions, and imaging in terms of echocardiography and cardiac MRI. I'm also the Deputy Editor for Education and Training for European Heart Journal Case Reports, and it's a pleasure to be invited by global women in cardiology to judge these wonderful cases.
Hello everyone, my name is Dr. Purvi Parwani and I'm a cardiologist at Loma Linda University in Southern California. And I'm honored to be a judge in this case competition organized by WIC Global Group. My subspecialty interests are cardiac imaging, particularly cardiac MRI, echocardiogram, and clinically I focus on women's cardiovascular disease. Again, thank you for making me part of this competition. Looking forward to seeing you all.
Hello everyone, I am Amardeep Dastidar. I'm one of the consultant interventional cardiologists at North Bristol NHS Trust and also at Bristol Heart Institute UK. I am an associate editor for European Heart Journal Case Report, and I am a big supporter of women in medicine, especially women in cardiology, and I'm delighted to be associated with this inaugural Women in Cardiology case competition project, and I look forward to judging the case competition.
Thank you, judges, for your introduction. The next case is presented by Dr. Hannah Crunch from Wales in the UK, and it is a case of myocarditis.
Hello everyone, my name is Hannah Crunch. I'm a cardiology trainee working in South Wales. I'm going to present a case to you today on checkpoint inhibitor induced myocarditis. A 75-year-old gentleman presented to our emergency department with an episode of transient loss of consciousness. He had been pre-syncopal for 8 hours prior to this episode. He had been lightheaded and nauseous. He was found at home on the floor by his family, extremely drowsy. He was brought in by ambulance, and on arrival to the department, he was found to have a GCS of 11. He had an unrecordable blood pressure, and he had a heart rate of 40 beats per minute. The gentleman was known to have a past medical history of renal cell carcinoma and had a radical nephrectomy a year previous to his admission. He'd also started immunotherapy 3 weeks prior to the submission for lung metastases. Although he was deemed to be palliative, he was thought to have a good prognosis in that respect, a number of years. He also had a past medical history of hypertension, hypothyroidism, and type 2 diabetes. So on his arrival, his electrocardiogram showed complete atrioventricular block. and he remained hemodynamically unstable with a heart rate of about 36 and unrecordable blood pressure and low GCS. It was out of hours in a district general hospital, and so an urgent temporary pacing wire was inserted. This was upgraded to a dual chamber permanent pacemaker the next morning. So because of the prolonged period of hypotension and hypoperfusion, he had a resulting acute kidney injury with hyperkalemia. And this was corrected over the coming days with nephrotoxic medication being held, IV fluids, and of course his bradycardia had been corrected. So he had an improving renal function at day 3 of 4 with normal electrolytes. He had an echocardiogram day 2, which found that although his septum is an incoordinate septum, his ejection fraction was greater than 55% with a normal left ventricular function. Despite this, he continued to deteriorate and become increasingly breathless over his admission, and on day 5 he acutely deteriorated and suffered, unfortunately, a cardiac arrest. His initial rhythm was VT, but prolonged resuscitation attempt was unsuccessful. There was a long discussion around what may have caused this acute deterioration. One possibility was acute pulmonary embolism. However, the patient had been on prophylactic enoxaparin since he had come into the hospital, and there had been no profound hypoxia and no sign of right ventricular strain on his echocardiogram. Sepsis was also considered, although he had remained apyrexial throughout his admission, and he'd also been receiving antibiotic cover. Myocarditis was also considered, given that he was being receiving immunotherapy, some of which is known to be associated with myocarditis, and he only started the therapy 3 weeks prior to the admission. One of the factors which contributed to this possibility as a diagnosis was the rise in troponin. So the high sensitivity troponin assay that we use in our hospital was found to be elevated at day 1, with significant increase again at day 4. And the day 5 sample was the day of cardiac arrest. However, that was added on to a sample taken in the morning prior to his cardiac arrest. But we can see he had an exponential rise in his troponin, which would support a diagnosis of myocarditis. However, we do know that troponin can be elevated in those with acute pulmonary embolism. So the patient went on to have a post-mortem examination, and this found that it was fully in support of a diagnosis of myocarditis with extensive lymphocytic cells throughout the myocytes. And both slides show this. The one on the right is closer and shows extensive myocyte damage with a loss of that red brick-like structure. So the cause of death for this gentleman was put down as acute myocarditis, secondary to immune checkpoint inhibitors. So immunotherapy is being increasingly used by our oncology colleagues. And the treatment that he was on, nivolumab, nivolumab is a fully human monoclonal antibody that binds to the PD-1 receptor on T cells. This, in turn, PD-1 would bind to PD-1 protein on a target cell, but by inhibiting that, it increases T cell immune activity and therefore immune activity against the malignant cell. Ipilimumab also works on T cells, but against the CTLA4 receptor. This would usually be there to downgrade or downregulate the immune response. By binding and inhibiting that receptor, T cell activity is increased. Both of these checkpoint inhibitors are known to cause myocarditis in less than 1% of cases. But they also have other cardiotoxic effects, which is why it is important that we highlight it in these cases. They can cause cardiomyopathies, atrial and ventricular arrhythmias, and pericardial effusions. So that leads us to what's so important about this case, but I think it highlights the varying ways in which myocarditis can present. So in this case, an arrhythmia. Immunotherapy has been increasingly used, as I said, by our oncology colleagues. And so anyone presenting to our department on these immunotherapies, presenting with arrhythmia, we should consider myocarditis as a possible cause, particularly when their troponin is elevated. In terms of a possible management for this patient, another learning point, which we will all come across at some point, is these patients are often the patients who are on it for palliative reasons. Therefore, as in this case, there can be a line as to what we can do. So in the acute urgent setting, where somebody is hemodynamically compromised, pacing strategy may be appropriate. But with a incurable cancer palliative diagnosis, things like inotropes and a higher level care may not be appropriate, as in this case, when their underlying cancer is unfortunately incurable. And that's another factor which we have to take into account. I hope this has been a good reflective case on myocarditis and immunotherapy, and something that I think we're going to see an awful lot more of over the coming years.
Thank you very much, Dr. Hannah Crunch, for presenting a case of acute myocarditis secondary to immune checkpoint inhibitors. So the next case will be presented by Dr. Mrunmayee Deshpande from Mumbai in India, and she will present a case of PCI in a young child with hypercholesterolemia.
Hello everyone. I would like to thank all the judges, the panelists and organizers for giving me this wonderful opportunity to present my case report in Women in Cardiology Global Case Report Competition. I have recently started working in the field of cardiology since the past 2 years. I have finished my internal medicine and now I have joined cardiology as a resident doctor. Presently, I am working in LTMG Medical College and Hospital in Sion in Mumbai, India. And today I am going to present an intriguing case report of a young girl who presented to us with acute coronary syndrome because of familial hypercholesterolemia, and I would discuss how we manage that case. So what exactly is familial hypercholesterolemia? It's an autosomal dominant genetic disease of lipoprotein metabolism because of mutations in the LDL receptors in the liver, which leads to elevations in the low density lipoprotein cholesterol levels. It can present in homozygous and heterozygous form. The homozygous form is extremely rare with reported incidence of 1 in 1 million cases, and it causes severe premature generalized atherosclerosis and coronary artery disease as early as even in the first or second decade of life. The management option mainly focuses on the drugs to lower the lipid levels and include the statins, the cholesterol absorption inhibitors, bile acid binding resins, and lipidopheresis. Newer treatments have come up in the past 5 years, foremost amongst which are the PCSK9 inhibitors. Other examples include the MTP inhibitors and mRNA inhibitors of apoprotein B. Despite medical management, patient can develop ischemia producing coronary artery disease and might require coronary artery revascularization. So coming to the case, a 10-year-old girl child born out of second degree consanguineous marriage presented to us with anginal chest pain on exertion since 1 month, which increased since 1 day to severe angina at rest. She also gave history of claudication in both her arms and legs while playing since 3 months. There was no family history of premature coronary artery disease or dyslipidemia. On examination, the most predominant findings were multiple painless firm nodules over the tendons of her knees and elbows as shown in the figure, and also on her knuckles and ankles, suggestive of tendon xanthomas. She also had corneal arcus. Cardiovascular system auscultation showed a murmur in mid to late systole, best heard at the apex. The electrocardiogram was done, which showed sinus tachycardia. She was having 3 mm ST segment depressions in leads V4 to V6 and ST segment elevations in the lead AVR and V1, suggesting a left main coronary artery disease or severe triple vessel disease with proximal left anterior descending involvement. Her lipid profile, as shown, revealed that her LDL cholesterol level was more than 5 times the normal range. Her VLDL cholesterol and total triglycerides were also elevated, leading the total cholesterol levels to be more than 1000. The family screening showed that there was elevated total cholesterol and LDL cholesterol in both her parents, but there was no history of any premature coronary artery disease or any skin manifestations. The echocardiogram was performed, which showed normal left ventricular systolic function. She had a flail mitral leaflet with causing moderate mitral regurgitation and mildly dilated left atrium. The parasternal short axis view at the level of aortic valve showed that the ostium of the left main coronary artery had a stenosis. There was no coarctation of aorta or supravalvular aortic stenosis. Ultrasound arterial Doppler was performed to evaluate her peripheral vascular disease, which showed diffuse atherosclerotic changes with narrowing in multiple large arteries. Patient was diagnosed with non-ST segment elevation myocardial infarction and with the possible diagnosis of familial hypercholesterolemia based on the Dutch clinic network criteria. And we started the patient on unfractionated intravenous heparin infusion. We loaded her with dual antiplatelets, that is aspirin and clopidogrel, which were weight-based. Statins and ezetimibe was started and anti-anginas were also initiated. She underwent coronary angiography from the femoral root, which showed critical stenosis at the ostium of the left main coronary artery, followed by another stenosis of 50% severity in the distal left main coronary artery. Her left anterior descending artery, as shown here, was relatively normal in the ostial part and the mid part, and the mid part showed a 50% stenosis in the LAD. The left circumflex coronary artery, or the LCX, was co-dominant, and it showed a 70 to 75% disease at the ostium, 90% disease at the proximal segment, and 70% disease in the mid LCX. Her distal LCX was filling retrogradely via the right coronary artery collaterals. Her RCA also showed some plaques. Based on this, we classified the patient as Medina 1, 0, and 1 as per the Medina bifurcation classification. Her lima, or the left internal mammary artery shoots, were also taken, which showed 80% stenosis at the ostium of the lima, thereby making it a very poor graft for coronary artery bypass graft. She also had an ostial stenosis at the vertebral artery, and left renal artery also showed some stenosis. She was consequently taken up for percutaneous coronary revascularization because of repeat episode of severe chest pain with dynamic ECG changes. She underwent PCI under general anesthesia using a right femoral access and 6 French femoral sheath. We used the provisional bifurcation stenting strategy. The left main coronary artery was cannulated using a 6 French JL3 guide. 2 BMW coronary guide wires were placed in the LCX and the LAD. The lesion in the proximal LCX was pre-dilated using a non-compliant balloon. An everolimus drug-eluting stent of the size 2.5 into 33 mm was deployed from the ostium of the left main coronary artery up till the proximal LCX. This stent covered the lesion in the left main coronary artery and the proximal LCX. This was followed by post-dilatation of the stent segment in the LCX and POT, that is proximal optimization of the left main coronary artery stent. A second drug-eluting stent was deployed across the lesion in the mid LCX of the size 2.25 into 18 mm. Post-coronary angioplasty and stent implantation, the check shoots revealed that she had a timid free flow in her LCX without any ostial compromise of the LAD, and there was no dissection. She was hemodynamically stable post-procedure without any complications. She was started on dual antiplatelet agents, aspirin and clopidogrel, rosuvastatin, ezetimibe, PCSK9 inhibitors, that is injection evolocumab 420 mg once a month was started. She was advised dietary modification. She was discharged after 5 days and remained asymptomatic for her cardiac condition around 4 months post-procedure. Her peripheral vascular disease and renal artery stenosis is being managed medically, and she has been advised monthly follow-up for lipid profile monitoring. We will do her cardiac stress test after 6 months, and we will also try to do a coronary CT after 1 year. Family screening was also advised to her. Coming to the discussion, medical literature has mainly focused on the drug therapy for familial hypercholesterolemia, and coronary revascularization in pediatric population is extremely understudied, and very few case reports are available in the medical literature. The coronary artery bypass grafting in a pediatric age group has multiple technical problems like the presence of the diseased lima graft, then requirement of an open surgery, technical difficulties because of small arterial grafts. The coronary artery stenting also with metallic stent also possesses unique challenges among pediatric age groups like increased risk of ISR or in-stent restenosis. The metallic stent can become undersized as the child grows. The presence of metallic stent alters the coronary physiology. Bioabsorbable scaffolds can solve some of these problems. However, further studies in pediatric age groups are needed. The best possible plan of management in our case under these circumstances probably was the use of drug-eluting stent using the provisional stenting technique, and we proceeded with the same and had good results, good short-term results. To conclude, familial hypercholesterolemia is extremely underdiagnosed, undertreated, and understudied disease, especially in young age group. Optimal approach and timing of intervention in these patients is unknown. Percutaneous coronary intervention by provisional stenting technique in our case resulted in a procedural success with resolution of acute coronary syndrome with a favorable short-term clinical outcome. However, long-term follow-up and further research on coronary revascularization in pediatric age group is required. Thank you so much. I am finished with the presentation.
Okay, well done. What a fascinating case. And how often do we see such signs with familial hypercholesterolemia? So one question I have for you is, what was your involvement with this case?
Actually, I am a resident doctor and I am learning, I recently started performing angiographies. So I assisted in the procedure. I also assisted in the management of the patient. Like when the patient was having severe angina and when she was having dynamic ECG changes, I was monitoring the patient, and I also helped in the counseling of the patient and also helped in the, I assisted in the procedure of the percutaneous coronary intervention.
And in terms of follow-up, have you noticed an improvement in her tendon xanthoma and corneal arcus? Is she feeling better in herself?
She actually underwent this procedure in April only, hardly few months ago. So, but till now she is doing very well. She has no angina and her claudication also has reduced. Her serum cholesterol levels have also decreased to some extent, and the xanthomas have not reduced till now.
Okay, brilliant. Thank you very much. A really fascinating case.
Thank you.
Thank you very much for presenting this case to us. Thank you. Welcome, Dr. Aaysha Siraj from America, who's going to present a case of a complication of the thyrofibrine.
Hi, everyone. My name is Aaysha Siraj, and I am an interventional cardiologist. Joined a Metro Health Medical Center affiliated with Case Western Reserve University 8 months ago. It's been a wonderful experience, and I just want to share one case of rare complication that happens. And my case has few take-home points that I myself have learned from this case. So my case is about thyrofibrine-induced diffuse pulmonary hemorrhage. So the background is diffuse pulmonary hemorrhage is a rare and devastating complication of glycoprotein 2B3 inhibitors used with high mortality. It is often misidentified and confused with other respiratory syndromes. So this is our case. He was a young 49-year-old male with no prior cardiac history, otherwise healthy, presented with ventricular fibrillation. He had a complete run of CPR with return of spontaneous circulation that were achieved within 40 minutes. And the repeat EKG, as shown on the right-hand side, shows ST elevations more prominent in 1 ABL, V4, V5. So the cath lab was activated. Patient was immediately taken to the cath lab. Prior to taking to the cath lab, he was loaded with 4,000 of heparin, aspirin, ticagrelor 180, and he was started on tirofiban. So this is our left heart catheterization as soon as we got him in the cath lab. And you can see that there is an completely occluded circumflex with some moderate disease in the modality. So after successful reperfusion of left circumflex artery, our patient went into PA arrest and was noted to have some bloody fluid coming from the endotracheal tube. The patient was really short of breath. He has received some CPR, and then he was intubated in the ED, as we know. But then there was unusual that he started bringing up this blood, and we thought that this is related to the resuscitation. So what are some of the thoughts that were coming at that present time? And then he started profusely hemorrhaging through the ET tube. So at that point in time, a second interventionalist come. We were coding the patient. We placed an intra-aortic balloon pump. He continues to bleed from the ET tube. The anesthesiologist got the glycoscope, and we saw blood coming from bilateral bronchus. We tried to resuscitate. We did autotransfusion. We did protamine. We did fresh frozen plasma, but it did not. He continues to bleed profusely. We were able to have some return of spontaneous circulation within 20 minutes. And then we thought that it is all related to tirofiban-induced diffuse pulmonary hemorrhage. And this is the glycoscope, which is actually showing massive amount of blood coming from the bronchus. So in conclusion, I mean, he continued to bleed, and unfortunately he passed away. This is some take-home point for all of us, that alveolar hemorrhage is often underdiagnosed, and it has been a routine protocol for most of the cath labs, or some of the cath labs, that they start tirofiban or any other glycoprotein 2B3 inhibitors when they see STEMI or thrombotic occlusions, in addition to aspirin and other antiplatelet therapy. The prevalence of tirofiban-induced pulmonary hemorrhage is around 0.9%, with the mortality as high as 50%. It has been reported, and it should be kept in the thought process when treating our patients. This potentially lethal course of pulmonary blood loss requires airway protection and correction of coagulopathy. And just to re-emphasize, and also for our fellows here, that there is no reversal agent of this medication available, and it is unclear that whether it is dialyzable or not. You can infuse platelets, you can give blood, but the mortality remains high. And that's the end of my case. And this was an unfortunate case, but this led to us change some strategies in our cath lab as far as glycoprotein 2B3 inhibitors are concerned in treating such cases. Any questions?
Again, this is a very interesting case, Aaysha, and it highlights, you know, too many blood thinning products, the complications that can potentially result, as you have presented here. So my question to you is, what was your rationale for giving the tirofiban at the initial stage in your clinical services before taking the patient to the cath lab?
So there was some debate that patient was appropriately loaded or not loaded. Sometimes there was no documentation, though, you know, when we are on call, we make clear points. So when there is inadequate P2Y12, there is some strategy, okay, give tirofiban. Patient has been resuscitated for quite some time. There is an institutional policy also with ongoing ischemia and chest pain, you know, try to give more potent, you know, antiplatelet therapy at that point in time. So that, I think that was the rationale, and keeping in mind he was a young guy, he would do well, you know, if the vessel would open up, you know, things like that. So I think that was the rationale of giving it too early, I think, in the ED. I think that was the deal with this case.
And one other question. As a result of this case, have your policies changed on giving tirofiban prior to taking the patient to the cath lab? It's
yes, absolutely.
Yes. From the UK. That's why I ask.
Yes, absolutely. Yes. So this was an eye-opening for us. We were, as an institution, doing routinely tirofibans, even with ongoing NSTEMIs or high-risk NSTEMIs, which we were admitting in units, and we were giving these tirofibans to them, including loading with DAP. We were giving them. After this case was reviewed in the committee, then with our fellows, and we have completely changed our policy of using tirofiban in the cath lab, as well as loading them prior to the cath. If the patient is not adequately loaded with P2Y12, then only we might consider, but then also there's a mutual decision. After this case, especially, you know, things have changed a lot.
And also perhaps in your really prothrombotic cases.
Mm-hmm.
Yeah. Brilliant, thank you.
Thank you, Aysha. That was a very interesting case. I actually have a few questions related to your ADAPT protocol as well. When you say P2Y12, what do you routinely load them with in the ER? Is it one of the more advanced, is it ticagrelor or not prasugrel, of course, is it ticagrelor, or do you just routinely give clopidogrel?
So we are 100% ticagrelor for our STEMIs. And then for our N-STEMIs also, we're trying to do ticagrelor loading doses.
And do you have cangrelor? I mean, even I'm
We don't have cangrelor.
Tirofiban. Oh, right. So you don't, but you would give a GP2B3A bailout.
Yes. Yes.
Now, but you don't have cangrelor, because that would probably be a more easily reversible agent if you're trying to revascularize him as well.
Right.
I just wanted to know, in a patient with ROSC, I mean, should your protocol have been different, considering that this wasn't a routine ischemic case? It was someone who possibly had extended CPR and would tend to bleed. Should it have changed, would you think, in retrospect?
Absolutely, yes. Absolutely, yes. So that was one of the thought processes, that there is a patient who comes with prolonged CPR and chest compressions. I think we were thinking in terms that trauma could just add up to all the picture, and that was our first thought process. We really have backed off from glycoprotein 2B3 inhibitors. We have only tirofiban available at an institution, and in post-ROS patients, we are just avoiding as a team that we should not be doing that. So that was one of the things that, when my patient was on the table and he was coding, that, it could be trauma related, but then we saw it for the glidoscope that was profuse bleeding, so it could be one of the components that added to the insult.
Thank you. Thank you for sharing this case. It takes courage to show the ones that didn't make it too. Thanks.
You're welcome.
The next case will be presented by Dr. Tin Sander Lin from the UK, and it will be a case of Minoka.
Hi, everyone. Thank you for giving me a chance to present my case here. My name is Dr. Tin Lin. I'm one of the cardiology S3 currently working in Kasahi Hospital. So today I would like to talk about my case, which is the myocardial infarctions with normal coronary artery, Minoka, presented as a STEMI attributed to the brain aneurysmal rupture. So introduction, first of all, I would like to run through a bit about what is Minoka. So obviously it's myocardial infarctions with no non-obstructive coronary arteries. So it's kind of the umbrella terms. It could be either type 1 MI, type 2 MI. So it can involve ST elevation MI, non-ST elevations MI, and unstable angina. And we see in the clinical practice Minoka as well, that as per the data, 6 to 8% of MI can present as a Minoka. So most common causes of Minoka could be the coronary artery spasm, myocarditis, and the plaque disruption. But any cause that can cause the type 2 MI, which impaired, which there is a mismatch between oxygen supplies and demand that can cause type 2 MI, should also enter categorized with the Minoka. So to manage the Minoka, it is very important to understand what is the underlying cause. So one of the causes which related with our case is the neurological insert. So that any acute neurological inserts, either acute stroke, either hemorrhage or the ischemic stroke, any seizure that can impair the oxygen supplies and demands, can have a damage to the myocyte, which can end up with the type 2 MI, and which can be categorized as a Minoka. So I'm going to talk more about the mechanisms of the heart-brain axis. So basically, this brain injury related with the heart dysfunction is due to the axis, what we call hypothalamic pituitary adrenal axis and catecholamine surge. So let's go through our case. So our case, we got a 50-year-old Caucasian male who have no cardiac background, no significant medical history at all. However, he is a long-term cannabis vape user, and he has a very interesting, strong family history of the cerebral artery aneurysms, IS, that two of them, like from maternal side, got the brain aneurysm. So this gentleman presented to the emergency department with a multiple episode of seizures. And on an initial ECG on arrival showed that clear-cut ST elevations stymied in the inferior leads with some reciprocal changes. And his GCS on arrival, because of multiple episode of seizure, the GCS is 7 out of 50. So we did the intubations urgently and subsequently admitted to the ITU. So here's the ECG on presentations. As you can see, there is ST elevations clear cut in 2-3 AVF and ST depressions in 1 AVL. But if there's an argument like with this kind of ECG, why don't you do the primary PCM urgently? But because of the atypical presentations with the multiple seizure and also the GCS dropped, we have very high threshold to go for the invasive procedure unless we got the more information about that. So we decided to do the urgent CT first. And CT without contrast, it showed the plausible hematoma. And hence we decided that we should stabilize the patients in ITU and to decide the further managements later on. During the ITU stay, and we did the patient was undergone the series of lots of neurological imagings, and then with the lasings and suggestions from the neurosurgical teams and radiologist team. So it's the CT, both with and without contrast, has been done. MRI brain has been done. CT angiogram has been done. All the images suggested that there is a aneurysm definitely in the anterior communicating artery with the hematoma and the evidence of previous hemorrhage. But there is some differential diagnosis from the neurosurgical point of view is like the features from the imaging suggest it could be the thrombus aneurysm, what they call the venous varix as well. So there's the imaging that I show is as you can see, the frontal lobe's got hematoma there. And so the patient was quite unfortunate during the ITU stay. It was quite prolonged, almost 1 month in ITU, because patients complicated with the hospital-acquired pneumonia and difficulty extubating, and also the acute renal injury, which require dialysis. So it was 3 to 4 weeks in the ITU. During there, so once patients more stabilized, acute, the recover from neurological point of view, totally GCS 15 out of 15, and also the renal recovers and everything. So the multidisciplinary team decisions, including the neurosurgeon, cardio, intense ICU teams, they feel that patients should evaluate it more with the cardiac investigation and optimize from heart point of view first before they decided for the invasive procedure for the brain aneurysm. So during the ITU, they did the initial echocardiogram, which showed the severe LV systolic dysfunctions with the ejection fractions of 30%. So after like almost 1 month, patients were stable, patient was stabilized, stepped down from ITU to CCU. And then we decided to do the elective coronary angiogram to see the vessel status. So it's quite interestingly, we saw that this is absolutely normal coronary arteries. So and hence we decided to do the further workup with the cardiac MRI. So cardiac MRI showed there is evidence of the myocardial infarct in the left circumflex artery, definitely there's with the myocardial edemas and then injury there. So during the stay, patients was treatment-wise treated with the anti-epileptic, and then patients were started the heart failure medication, then subsequently up-titrated to the max. Then we decided to put the ICD because patients presented with the ventricular tachycardia in the initial admissions in the ITU. So we decided to put as a secondary prevention. After ICD inserted, we transferred the patient to the neurosurgical unit for further management for the aneurysm. I would like to show you some images. So this is the coronary angiograms. As you can see, it's a PA aerial quarter view. So the left systems, as you can see, circumflex and LADs, everything is normal, because the MRI suggests the circumflex got some territory MI. So as you can see, the MRI got some late gadolinium enhancements here. It's got lesion that show that myocardial infarctions in the second flex heart, second flex. So based on our case, we would like to discuss more about the relationship between the brain and the heart. So the most common mechanisms explained by literature is because of the catecholamine surge, which was catecholamine was produced via the epinephrine or norepinephrine from the adrenal axis. And at the same time, it's because of the brain injury, the sympathetic and parasympathetic nervous systems will be activated, and it can have a direct injury to the brain. So because of this hormone, catecholamines, epinephrine, norepinephrine, and sympathetic activity, the net effect for the patient is blood pressure high and increased oxygen demand and possible the vasospasms. All these mechanisms causes the brain's cardiac insult, which end up with the type 2 amines and Menoka. So in our case, there is definitely the evidence of amine with the ECG changes, inferior STEMI, and also the elevated enzymes. The troponin was 1,800 in our case, and echographic picture, CMR, so AQMI, which indicate the AQMIs, although angiographically normal. So Menoka, it could be induced by various causes. Either it could be cardiac cause, or either could be the extracardiac causes. Although it's common, it's not common, like 6 to 8% only. It's not benign, so we need to take it seriously. So management-wise, like I said, it's very important to understand the underlying cause. What is the cause? So although the commonest causes are plaque disruptions, myocarditis, that we would like to highlight together with our case, acute neurological insults and other possible causes, substance abuse should also be considered. Yeah, so learning point based on our case is just, we would like to highlight that all the STEMI is majority of STEMI present as a type 1 ACS with definitely there is obstructed coronary arteries, but stay can possible without any obstructions and present as a Menoka, which is our case. And to manage that, to get appropriate management and treatment, that in proper investigation and understanding the underlying cause is very, very important. And also we would like to suggest that before we decided for the invasive procedure, always have a high threshold to do that, and you always need to consider about any other possible causes like neurological insult, acute brain injury, and such before we head with the invasive intervention. Because in our case, if we decided to do the primary PCI, it would be very catastrophic. So overall, it's like the basic principle, proper clinical examinations, history takings, and appropriate investigations is all very, very important in managing the patients, which can be life-saving. Thank you very much. Any question?
Hi, thanks, Tim. That was a very interesting case. You did mention this person was a cannabis user, correct? So it could have been that the coronary issue or the Menoka was a direct effect of the cannabis-induced vasospasm as well. Did you test for anything additionally during the angiography? Did you do an acetylcholine test, anything to that effect? And
yeah, that's a very, very, very good question. That definitely we thought about it. We asked the patients about their cannabis use beforehand as well. So obviously, before the onset, patients use 1 hour ahead because patients is a daily user. And there is already some case reports saying that cannabis can cause the ACS as well. So but the thing is that we don't think that's the possible causes. We got 2 reasons. First of all, it would be very, very unlikely to have the double pathology at the same time together with the brain injury with the bleeding and also at the same time with the cannabis-induced ACS. Which state could be possible, we cannot 100% sure. And like you said, we didn't do this, the acetylcholine challenge because that angiogram was just elective and it was just like almost 1 month electively. then.
All right.
Yeah.
That's interesting, actually. So before you did the elective angio, what was the ECG? Did he have cues or was it a normal ECG?
For the angiogram?
Yeah,
so
and there's 1 month later.
Initial ECG was
No, 1 month later.
1 month later, there is a Q wave there. Yes.
Okay, right. And
ECG, yes.
okay, what did you treat him with for the coronary issue?
So so heart failure medication, everything. We even adjudicated to the we adjudicate every medication, and for the coronaries, because it is normal coronary, and then we discuss with the surgeon with the risk of benefits and then risk of bleeding, and regarding giving the antiplatelets. But we decided, since normal coronary and they got the further management to do the procedure and clipping with the brain aneurysms and hematoma, we decided not to give it.
All right. Thank you very much, Tim.
No worries.
Well done.
No worries. Thank you.
The next case will be presented by Dr. May Dadiri. It's a case of stent deformation.
Okay, so I'm May Dadiri. I'm an interventional cardiology fellow in Dr. Fouad Hospital in Cairo, Egypt. I'm actually one of 2 female interventional cardiologists in the whole country. And I'm very passionate about this. So the case I'm going to be presenting today is longitudinal stent deformation, the overlooked complication in the era of new generation stents. And just to give a brief introduction of this, well, the development of drug-eluting stents has revolutionized interventional cardiology practice. And there are so many technological advances in stent designs, making them much, much easier in their deliverability. And this actually allows interventional cardiologists to take on bolder strategies and in treating complex lesions that were in the past just referred to cardiac surgeons. And the main focus is being towards developing stents that have thinner struts and are more flexible in crossing tortuous vessels while preserving their radial strength. And this has made the stents more liable to longitudinal stent deformation, which, if unnoticed or inadequately treated, can lead to very adverse complications, such as early stent thrombosis, and this can complicate into the need of the patient for bypass surgery, or even as grave as mortality of the patients. So I'm going to be presenting a case of a 61-year-old Caucasian male patient. The patient presented to our emergency department with unstable angina. He has no known risk factors except being dyslipidemic, receiving 20 milligrams of rosuvastatin per day. Serial sets of his cardiac enzymes were all within normal values, and his ECG showed a normal sinus rhythm with no ST segment changes and no arrhythmias. His echocardiography did show a good left ventricular function with an ejection fraction of 64% and hypokinesia in the infraseptal wall. So we took the patient for a diagnostic coronary angiography, and we did this through the right radial approach. And as we could see here, the patient had significant lesions in the mid and distal segment of the left circumflex, as well as a significant lesion in the mid segment of the left anterior descending artery. The right coronary artery was a very tortuous and calcific vessel, showing multiple lesions along its course, giving it this beaded appearance. And we anticipated at this point that intervention in the right coronary artery was going to be a very lengthy procedure, posing a higher contrast exposure and radiation exposure to the patient. And so we thought, if it takes time, we're just going to delay the intervention to the left system to another setting. So we proceeded to percutaneous intervention, still through the right radial approach. We cannulated the right coronary artery using a Judkins Wright Curve 4 guiding catheter, and we managed to engage the artery, but we could not manipulate any wires through the tortuosities and calcifications. So in aims from us to increase our guiding catheter support, still through the right radial axis, we engaged the RCA using an Amplatz left Curve 1 guiding catheter, and we managed to manipulate 2 run-through wires, and those are hydrophilic wires, through the posterolateral branch of the right coronary artery, as well as a branch of the posterolateral artery itself. And then we tried to introduce small compliant balloons to predilate and just prepare the vessel for stenting. But even our smallest balloon, compliant balloons, that was a 2 millimeter balloon, could not cross through the tortuosities. And so we used a guide liner catheter for support in delivering our equipment. this was actually successful, and we managed to pre-dilate the RCA using 2 millimeter balloons and escalating up to 4 millimeters in diameter of compliant balloons. And then we found, or we noticed that there was a dissection in the right coronary artery that extended from its proximal segment and up to its mid segment. So we placed our first stent. It was a sirolimus-eluting stent. It was a long 30 millimeter stent in the distal segment of the right coronary artery. And then we tried to retrieve the wire that was jailed in the branch of the posterolateral artery. But in doing so, we kept losing guiding catheter support the whole time. And so we just thought we'd keep the wire in its place and just advance 2 more stents, making our stents just covering the proximal up till the distal segment of the right coronary artery and post-inflating at the sites of overlap. Afterwards, we did forceful traction on the wire and actually managed to retrieve the jailed wire. But we then noticed, as we can see here, that the stent in the proximal segment of the right coronary artery had been deformed. And this was probably due to the fact that with our forceful traction on the wire, the guiding catheter got more deeply engaged into the right coronary artery, thereby deforming the proximal edge of the stent. And this is here the deformation, as we can see, without contrast, and here with contrast. So we attempted to deliver several small non-compliant balloons through this deformed stent, but all our attempts were unsuccessful. And the patient got fatigued, us as operators as well. And we found that since the patient had received a lot of contrast, the procedure was very much prolonged. And since he was hemodynamically stable and we had a TIMI3 flow in the right coronary artery, we decided that we would just stop right there and keep the patient on glycoprotein 2B3A inhibitors in the cardiac CCU unit for 48 hours. 5 days later, we took the patient back into the cath lab. And from the very beginning, we thought we'd use the most support we can get in this intervention. So we went straight up through a right femoral approach using an Amplatz left curve 1 7 French guiding catheter. And we used microcatheter also to help us in manipulating our wire through the right coronary artery. This was also a run-through wire that could be manipulated. No other wires could cross the deformed stent. And then we pre-dilated the artery using our smallest balloons. That was a 1.25 millimeter non-compliant balloon. And then we kept escalating until we reached 4 millimeter non-compliant balloons, expanding the stents, the deformed stent especially, as much as we could through the process. And then we placed again, sirolimus-eluting stents in the mid to distal segment of the right coronary artery and another stent overlapping with it up to the ostium of the RCA. And then we did a post-dilation at the site of overlap. And as we can see here, the results were excellent. The stents were very well expanded. And here's the image with contrast. So afterwards, we just went smoothly on to performing PCI to the LAD with 1 drug-eluting stent and the circumflex with 2 drug-eluting stents. The patient remained uneventful for 24 hours, after which he was discharged in a very good condition. So there are very important points I'd like to emphasize on in this case that led to longitudinal stent deformation. First of all, in our case, the RCA was a tortuous calcific artery, and this led to frequent loss of the guiding catheter support, urging us to jail a wire in the posterolateral branch. Not only that, but the only wire that could be manipulated through this artery was a hydrophilic wire, which is reported to pose higher risk of difficult retrieval after jailing. Forceful traction on the jailed wire pushed the guide catheter deep into the RCA, crimpling its proximal edge. And also in our case, we had to use guide catheter extensions to overcome the poor guide catheter support and facilitate stent and balloon delivery. And this is actually one of the things that is reported to contribute to longitudinal stent deformation, especially by Henradi et al., who studied different cases, and guide catheter extensions were one of the major reasons. Also, in our case, we used thin strut drug-eluting stents to ensure better deliverability through the tortuous RCA, but unfortunately, this did come at the expense of poor longitudinal strength of the stents. So the learning points here are very, very important. Longitudinal stent deformation is an overlooked complication that may occur when we use newer generation thin strut stents, especially in tortuous and calcified vessels, and its incidence increases with deep engagement of the guiding catheters, use of catheter extensions, and retrieval of trapped guide wires. Also, from this presentation, I'd like to emphasize on the importance of all interventional cardiologists to be well aware of this complication, because it could be very easily missed. And just when you're working on a tortuous artery, just be sure that you just remember that this complication may occur because it may lead to stent thrombosis. Finally, I'd like to thank you all for attending, and I'd like to thank all my colleagues in Dar el-Fuad Hospital, especially Dr. Islam al-Bahiri. He is an interventional cardiologist that helped me a lot in preparing this case. Thank you very much.
Thank you, Mai. That was a fascinating case. Lots of learning points as well. I have to ask, I mean, I know there might be limitations in Egypt because I work in South Asia and we have similar limitations, but did you think of imaging this case and optimizing the stent placement with imaging?
Especially at the second session, we thought that we might go in with an IVUS, but of course we do have several limitations and not everything is available. Of course, we don't have anything, IVUS and FFR are not available just ad hoc when we're working for the first time. We need to ask for them before we work to be scheduled. And also in this case, it was not really available. Had it been available, of course, it would have been of great use, and this is why it's very, very important that we use imaging in such a case. Of course, yes.
That's right. And when we don't get it, we actually use stent boost. When it's a sort of distortion, that can also help. And as regards the guideliner, could you tell us about your experience with it, and I mean, how it dissect? The guide extension induced dissection.
Yes.
How might you prevent such a complication?
Well, you need to be very familiar with handling your equipment, especially when the guideliner goes through tortuous arteries. It has been in so many studies that it could cause a dissection. So you need to be sure that you know how to handle your equipment. You need to be very comfortable with using a guideliner catheter before using it for the equipment, especially if you take a balloon.
Sorry, I missed that.
Especially when you're working on a tough case like this one.
Absolutely, absolutely. And I think if you take a balloon, that sort of reduces, it's called guideliner BAT, a balloon assisted technique. If you go take the guideliner with the balloon, that sort of prevents a razor effect and a dissection. Congratulations, very, very well presented case. Sabiha, I think you have a question.
May I ask you one question? Lovely presentation, first of all. In terms of follow-up for your general cardiologist, what advice would you give them? Could, if this patient remains well and asymptomatic, in 12 months down the lane, are you going to allow, would you recommend that the general cardiologist can discharge this patient, or would you want to keep this individual under a longer follow-up period?
Well, it depends on your end result that was achieved during your angiography. And in our result here, we took multiple images with different views, and we made sure, as I showed in the presentation, that the stents were very well expanded as much as we could. And we kept the patient for 24 hours in the CCU, and I think we kept him for a week in the hospital. And the patient was doing really fine. We usually do a monthly follow-up after that for 3 months, and then the patient could be followed up every 6 months.
Thank you very much. Thank you for a great presentation.
Thank you. Thanks a lot.
Hi, my name is Fielder Cam, and I'm the Assistant Editor for European Heart Journal Case Reports. EHJ Case Reports is an open access peer-reviewed journal of the European Society of Cardiology, and unsurprisingly, we specialize in publishing case reports. We're excited by a journal by all sorts of case reports, but more importantly, we're interested in the learning points that can come from case reports. I'm very grateful to the WIC global team for asking us as a journal to partner with them in this competition. The cases presented today have all been truly exceptional and have all had amazing learning points. They demonstrate the strength of this competition specifically, but more so are a testament to the women in cardiology community. On a personal level, I feel very privileged to have been able to work with a number of the WIC global team. They're amazing role models, not just for women in cardiology, but for cardiologists as a whole. The case quality was so amazing, and unfortunately there can only be one winner. However, I would encourage all the cases that don't win today's competition to submit directly to the European Heart Journal case reports. They all have important messages that the wider cardiology community would benefit from. But without further ado, As there only can be one winner, we should get on and announce that. The winning case we publish free of charge in European Heart Journal case reports. And the winning case is CV imaging in COVID by Dr. Ranjan and colleagues. Congratulations to the winners. The case was really, really interesting and well presented. I look forward to seeing the case published in the journal. Thanks very much.
Congratulations to our winner, Dr. Pragya Ranjan from New York. We're also grateful to the panel of judges for their time and support on this project, and to the European Heart Journal case reports for the collaboration. Thank you to everyone that submitted cases and those of you who joined us on this webinar from all over the world. We are thrilled to have met you virtually and are really looking forward to collaborating on projects and opportunities with you in the future. We also value your feedback, so if you could please fill in the feedback form that will reach you at the conclusion of this webinar, that would be fantastic. And you can get in touch with us anytime via email at womenincardiologyglobal@gmail.com or directly on Twitter at global_WIC. In the interest of time, we will officially conclude the webinar now, but we'll be around for a while and you're all welcome to hang around, grab a cup of coffee or a drink and network virtually. Thank you very much and have a good day.